Welcome to the Agency for Healthcare Research and Quality's national webinar on artificial intelligence tools to improve provider effectiveness and patient outcomes. While people are still logging in, I'm going to get us started. I'm Lieutenant Commander Stephanie Pitts, and it is my pleasure to moderate today's webinar. I currently serve as a Health Scientist Administrator for AHRQ's Digital Healthcare Research, or DHR program, which is part of the Center for Evidence and Practice Improvement. DHR's mission is producing and disseminating evidence about how the evolving digital healthcare ecosystem can best advance the quality, safety, and effectiveness of healthcare. To fulfill this mission, the program produces actionable findings around which digital healthcare technologies can improve care for our key stakeholders, patients and caregivers, clinicians, and health systems. We will discuss 3 of these exciting projects during today's webinar. Here's the agenda for today's webinar. Please note that we're recording the webinar and that the recording and slides will be available on the DHR website in a few weeks. You will be notified by email once they are available. We are pleased to have with us today an esteemed group of presenters, including Dr. Jeremiah Hinson, Dr. Jessica Keim Malpass, and Dr. William Xu. This webinar is accredited by Affinity CE. If you are interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For purposes of accreditation, let me note that AHRQ, SD Solutions, and Affinity CE have no financial interest to disclose. Dr. Hinson is the Medical Director of Danaher Diagnostics. Dr. Keim Malpass holds stock options in Artera AI. Dr. Xu has received research support from Early Diagnostics Incorporated. He is also a consultant for Lung Life AI Incorporated. Please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the question and answer panel located to the right of the PowerPoint slides. Please include the presenter's name or their presentation order number, first, second, or third, with your question. As a reminder, participants are in a listen-only mode, so to ask questions, you will need to use the Q&A panel. This slide outlines the learning objectives for today's webinar. By the end of this presentation, you should be able to, 1, discuss how an AI algorithm can be developed into an EHR-based clinical decision support tool and optimized for use in the emergency department to improve diagnostic accuracy. 2, describe how AI tools can simplify complex and voluminous patient data into enhanced data visualizations that support clinical decision-making, facilitate earlier interventions, and reduce cognitive load for providers. 3, identify strategies for integrating AI algorithms into the clinical workflow to enhance efficiency, reduce false positives, and ensure timely diagnostic follow-up imaging. And now it is my pleasure to introduce our first presenter, Dr. Jeremiah Hinson. Dr. Hinson is an emergency physician scientist at Johns Hopkins, where he leads cutting-edge initiatives in artificial intelligence and digital decision support through the Center for Data Science and Emergency Medicine, CDEM. Much of the work performed at CDEM has been funded by AHRQ and has included the development and implementation of machine learning models to enhance clinical decision-making for emergency department triage, acute kidney injury, and multiple infectious diseases. And now I'll turn it over to Dr. Hinson.
Thank you very much, Stephanie. As you mentioned, the real impact or the aimed impact of our work is to develop decision support that enables data-informed decision-making in the highly complex emergency care environment. So I'm an emergency physician, and I work in this environment quite a bit. Emergency departments provide care to 150 million Americans. We take care of that many visits at least every year, and the number goes up each year. But emergency medicine is practiced in the most hazardous decision-making environment in modern medicine. Emergency departments are subject to extreme overcrowding. In 2007, there was a report from the Institute of Medicine indicating that if things didn't get better, the whole system could break down. Things are much, much worse. I worked a shift within the last 7 days at Johns Hopkins where we have 65 beds to care for patients, and we had over 130 patients there seeking care, meaning twice the number of patients as we have space to care for them. There are very frequent interruptions causing task switching in emergency medicine. At the turn of the century, even before we had the EHR and more frequent interruptions, it was shown that every 6 minutes, emergency physicians had to switch tasks. So imagine trying to manage complex disease and doing that. The EHR has been really good for some reasons we'll talk about in a moment, but has pulled us away from patients. And studies have shown that emergency physicians spend up to 2/3 of their time inside the computer and away from the patient. Spaces have been optimized for privacy, which is really good. But that also means that there are doors and it's more difficult to see patients who may be unstable in modern emergency departments. And then finally, emergency medicine is practiced in an open loop learning system. So ordinarily you would want to be able to get audit and feedback to learn whether the things that you did previously had a positive impact or not. And in emergency medicine, that's just not possible. We don't really get much information once the patient leaves our emergency department. So over the past 15 years, things have really changed drastically in the emergency department. In 2010, when I was training, we would take history on a single sheet of paper. This is called a T-sheet. It takes a couple of minutes to complete. That's all that we would document. As you can imagine, there are many problems with that, but it also kind of frees up a lot of time. In 2020, we spent a ton of time in an electronic health record. This is what this is a picture of on the right. And we're capturing a ton of data, right? And we're just practicing medicine in a totally different way. This same thing has totally revolutionized the way that data are stored and how usable those data are. So if you look at JAMA or New England Journal of Medicine, major papers, this is reflected in that the sample size that we're able to analyze and try to interpret to improve care. Same thing is true in the practice of medicine. So our lab at Hopkins is really focused on trying to understand whether we can use these data and then artificial intelligence. And I'm really talking about different types of machine learning. That's most of what we are talking about when we talk about artificial intelligence in practice. Can we use them for clinical purposes? Can they outperform the current standards and can they be translated to clinical practice? And I'm going to show you 3 examples of that today. So there are 4 major decision points in emergency medicine. The first is triage. The patient arrives and we have to decide within 3 minutes how sick that patient is. And that determines their entire trajectory throughout the emergency department. Then there's diagnosis, not just what does the patient have, but what diagnostic tests should we order? How do we interpret those results? What is the diagnosis? Treatment decisions. What treatment should I give? Sometimes we're doing that before we even have a diagnosis and giving things like IV fluids. Others are specific to the diagnosis that we've already made, like antibiotics. And then the final decision is disposition. Is this a patient who could go home? Do they need to come into the hospital? And if they do, should they be observed? Should they be in an inpatient status? Can they go to a regular floor or do they need to go to an ICU? All these decisions are being made within about 6 hours for every patient. And every emergency physician is caring for up to 20 patients at a time. So you can see how many decisions are being made in the complex environment that I described earlier. So anything we can do to support that decision making is great. And so we're trying to transition to a point where we're making the same decisions, but we're really leveraging all the data that we've collected from prior encounters to inform the current encounter. And we're definitely not trying to replace the human being with artificial intelligence, but we're trying to meld those 2 minds, the human intelligence and machine intelligence, to arrive at a better outcome for patients. So I'm going to start first with triage. We've done a ton of research. Others have done a ton of research showing that triage is one of the most important decisions that gets made in the entire hospitalization and really drives all of the downstream decisions. This is the current standard. It was developed in 1999, was a huge advancement at that time to standardize things across the country, but it's become a bit outdated due to modern practices. So levels 1 and 2, we still use a 5-level system, but levels 1 and 2 are assigned to patients who need care right away, and they go directly into beds. Levels 4 and 5 are the less acute patients, and they can often be cared for in a different area of the ED. Both of those work streams are very clear and have clear paths. But if you fall into this middle group, 3, your path is uncertain. Some of those patients are really sick and some are not. Unfortunately, across the country, most patients, up to 70% of patients, fall into level 3 within this system, and that's because it's really driven by anticipated resource utilization. The assignment of scores is also highly variable, with around 60% agreement between nurses for every patient, and the sensitivity for critical illness using this tool is pretty low. So the first tool that we developed within our group, and this was really led by a biomedical engineer and one of my longtime collaborators, Scott Levin, was to use artificial intelligence, and we're using machine learning here, and specifically random forest machine learning models, to assess the acuity of patients based on their likelihood of having 3 specific outcomes. So to build these models, we use at least 100,000 encounters from every hospital that we would deploy this tool at. And we use the same data that nurses are already collecting, so no change in workflow. We use the chief complaint of the patient, why they came there, their vital signs, their demographics. We exclude race from the demographics, so it's really just sex and age, arrival mode, and medical history that's pulled from the electronic health record. We have 3 machine learning algorithms that estimate the likelihood for each patient in real time of having a critical care outcome, which we define as going to an ICU or dying, having an emergency surgery, or requiring hospital admission. And then we take all 3 of those outcomes, we estimate a probability, and we use risk thresholding to assign patients to a recommended acuity level. And that is presented to the patient, to the nurse, as I'll show you in the next slide. And what we're able to do is really move the thresholds to drive patients into the triage levels that we want. And you can see what we did at Hopkins, and what is usually the need is to drive down the number of level 3s. And we do that by safely driving up the number of patients that can be cared for in a fast track or rapid care area, and allows us to move patients through much faster. This is what a mock-up of what the tool looks like to the nurse. So the nurse interacts with the patient in the same amount of time, gathers exactly the same data. When they enter those data into the computer, they are sent up to a cloud. And in the time that it takes the nurse to advance to the next screen, literally a click, those data are processed by the algorithm, the probabilities are generated, the risk thresholding is applied, and a triage acuity recommendation is made. The nurse sees that recommendation, sees an explanation of why that recommendation was made for that individual patient, and then they can either assign an acuity that matches that, or they can disagree with it. And if they disagree with it, they have the option, if they choose, to send a note back to the developers of our algorithms to say, I don't think this was right in this case. And then there is a feedback loop that we don't have time to talk about today, but we can also communicate back to the nurses about whether their intuition was correct, or whether the machine learning algorithm had a better idea of the acuity. And there's a trade-off. Sometimes the nurse can see things that the algorithm can't. When we put this into the real world, and then we have a lot of publications from different hospitals about this now, this is what happened at Hopkins, similar things happen in other places, we see that the assignment of triage acuity was much more accurate. So if a patient is going to go on to die, or to be admitted to an ICU, or to require an emergency procedure in the first 24 hours, you want them to be assigned to level 1 or 2. And what we see is that we didn't increase the number overall of 1 and 2 level patients, but we increased the capture of critical illness within that designation. We also see that even though we increased, if you remember, the number of patients going to level 4 and 5, that low acuity group, the rate of hospitalization didn't go up in that group. So they were able to be safely cared for in a fast track area, and just enabling them to move through the department quicker. And what that translates to in terms of actual movement and patient-oriented outcomes is we see that patients who have critical illness and need to go to an OR, to an ICU, they got to that OR or ICU in an hour to an hour and a half faster. And in certain populations, like those with chest pain, we see even bigger effects, and up to a 3-hour improved time to procedure for patients who have critical illness. Across the entire population, we see big gains as well. At Hopkins, we saw a 20 to 30 minute decrease in door to disposition time for all patients. And when you do this, it just opens up capacity within an emergency department, allows you to care for more people. We recently put it in a large health system in Connecticut, and saw we were able to care for 8% more people afterward. And this translates to cost savings, obviously. So what about diagnosis and treatment? I've shown you we can do it in triage. It was a huge success story. This tool, Triage Go, is now being disseminated across the country. Can we do it for diagnosis and treatment? So we have a study right now, which is also funded by AHRQ. The prior study was funded by AHRQ as well. And this study is looking to see, can we identify patients who are at risk of acute kidney injury and maybe prevent or lessen the injury that they're going to have using machine learning? Why acute kidney injury? Acute kidney injury is an under-recognized problem. It's the second most expensive condition in all of hospital medicine, second only to sepsis. It's associated with a longer hospital stay, more expensive hospital stay, and higher odds of death. The reason it's so hard to detect, especially in the emergency department, is the thing that we use to detect it is an indirect marker of kidney function. So the kidneys stop working well, and then this thing called creatinine builds up, but it may not build up for 2, 3, 4 days after the injury. And so when we see the patient in the emergency department, we really have no signal to know that they have kidney injury. So this is a paper that was published a few years ago where we showed that we can take patients, we can take the data that are already being gathered in the electronic health record. And the image on the left is just, it's from the paper, and we can share this afterward, but we developed machine learning algorithms that process those data and then put them into a machine learning algorithm. And within 1.5 hours, 1.7 hours after the patient arrives, we can give a really good risk estimate of whether this patient is going to develop acute kidney injury. Or we can do it within 24, 48, or 72 hours as we choose. You can see the overall accuracy was 80%. We're representing that with something called the area under the curve of the receiver operating curve. And that our sensitivity and specificity is not perfect, but around 72, 73% for each. What's really important is the data on the right here. So if you look at this patient, this is a real patient from this study. At point A, this patient developed an illness in the outpatient setting, a GI illness, had a lot of fluid losses, presented to the emergency department at point B, had no signs of kidney injury at that time, but at point C, they manifested. This is 24 hours later. They're on the inpatient service now. And then at point D, the kidney function had gotten much worse, and it was much clearer that they had kidney dysfunction. And all of this time between these points, our prediction model allows physicians to know that this is going to happen and to treat them differently. So it enables us to provide better care much earlier. So we have this R01 award that we're currently working on, and it has some real big aims. So we've completed a lot of these. So we've taken the model that I just showed you, and we have a publication under review now where we are actually making that algorithm be applicable to all emergency department patients by developing some methods to deal with missing outcomes, which is pretty challenging. We have really done a lot of work to understand the optimal way to interact with human beings in the emergency department, how to provide that decision support. We're collaborating with our IT leadership of the hospital to integrate the tool into the electronic health record to supply decision support in real time. This is an example of a module when a patient is being prescribed medications that may be bad for the kidneys and they're at increased risk. We can relay that information to the provider in a way that doesn't necessarily stop them from being able to do things, but gives them additional information. And then we're implementing this and measuring how well we do with implementation, and then also how effective the tool is. And we're doing that at 3 hospitals within the Hopkins system. So that work is ongoing. I'm going to tell you about another project here on this final decision point, right? The one that may be the most important, determining where a patient goes after the emergency department. Is this a patient that is safe to go home? Do they need to come into the hospital? And if they need to come in the hospital, to what level of care? And this study, again, like the others, received funding from AHRQ. So I'm sure that you all remember the pandemic that we recently went through. There was a lot of uncertainty across the world in every facet of society. And within emergency departments, it was particularly acute. It was very, very stressful. We had pandemics, waves of the pandemic coming. We didn't know what would come next. And then at the individual patient level, we had never encountered this disease before. So we did not really know what the trajectory of the disease was. Because we had had previous success with the triage tool, our hospital leadership came to us and said, please help us develop a tool that can help us optimize patient management across the system and distribute our patients better across the system, because we were admitting too many patients and sometimes admitting the wrong patients to the hospital and underutilizing things like field hospitals. And so in collaboration with a lot of folks across the entire health system, across emergency medicine, critical care, internal medicine, we did a project that usually lasts about 5 years in 6 months. So we curated an incredible amount of data from the electronic health record. We used tools that we had already developed through grant funding and things that we were already working on from AHRQ to then transport those over and leverage them to create machine learning models specific for patients with or with suspected COVID. And then we integrated that into the electronic health record, and I'll show you what that looked like. Okay, so this is the way things worked. It's similar to what I showed you before. There's a lot of information here, but I'll just kind of walk you through this. So in point one, I'm just showing you that we took predictor data from the electronic health record, just things that we were already collecting. Why did the patient come? What medical problems do they have? What are their vital signs and how are they changing? What oxygen support are they requiring? What are their lab results? We then took those data, we used them as predictors. We put them into machine learning algorithms, and we developed two algorithms. One predicted whether the patient was going to have a critical care outcome or require ICU resources within 24 hours. And then the other predicted whether the patient was going to require inpatient care, things that couldn't be provided outside of a hospital within 72 hours. And then just like I showed you with triage, we applied risk thresholds, and this time we put them into risk levels. The reality is that the continuum of risk is not really based on levels, but to make it easier for people to interpret, we provided an infographic like this that allows you to see a level, but shows you that it's continuous. And then we gave soft recommendations that if a patient was high risk, you should consider sending them to an ICU or a step-down unit. And as the risk goes down, you may consider going to the ward, to a field hospital, or discharging the patient home. And then we embedded this decision support right within the electronic health record. So if you ever ask anyone to step out of the electronic health record or out of their workflow in the emergency department, your tool will never be used. So we embedded this decision support within the electronic health record, but we allowed people to see a very brief message here saying this person has a risk level of 2 out of 10. They have low risk for the critical care outcome, low risk for inpatient care needs. If you'd like to know more, you can click here. They can click in, see the infographic that I just showed you, or see additional information as well in terms of how the tool was developed. They could watch a video about how it was developed. Usually you only need to do that one time, but you could go back and do that as many times as you wanted. And they could also access all of the other COVID-19 specific resources that were available to them at the time. So what happened? Well, we looked at the accuracy of our tool in data where we trained it in the data that we had on hand, and then we validated it out of sampling those data, and we saw the performance was really, really good. Then we put it into the electronic health record and we let it run in the background without providing any decision support on the front end. And we saw that the accuracy remained high. And then we put it in the live clinical environment and started supplying information to clinicians, what I just showed you. And we saw that the predictive accuracy remained high. And we continued to monitor this throughout the time and ensure that we weren't getting any degradation of prediction accuracy. Did it matter for patients? It seemed that it did. So the rate of ICU upgrade in patients who were high risk went down from 7.5% to 3.9%, so a relative decrease of 31 to 49%. And we also saw a decrease in mortality in the highest risk patients, those who were in the 9 to 10 range. It went down from 7% to around 3%. This was a study that was, we tried to account for confounders, but obviously this was done in an uncontrolled environment where we were really just trying to support better care. And so some of these things are likely due to our decision support and some may not be, but we saw trends toward improvement in multiple different areas. So I'm coming to the end of the time that I have to talk about these things, but I think we've shown you some examples here of how we've taken these data that are being stored and are currently just sitting in massive databases, and we're leveraging them to enable better decision making. And I think what we're sharing here is just the very beginning of how these types of things are functioning, and you're going to see some examples of even more complex algorithms and interesting ways to apply these. We've shown you, things at triage, diagnosis, treatment, and disposition for emergency medicine. This is the center that we work in. We're very focused on human factors engineering as well as data engineering and data science. So we work with people from the Maryland Institute College of Art, as well as the Whiting School of Engineering, to try to develop algorithms and clinical decision support that people can actually use and that is helpful rather than being an impediment to care, which it can very easily become. Just want to acknowledge that the ton of people that did this work, the many organizations, including AHRQ, that have funded our work. And then this is my email address. I'd be happy to connect with anyone who is interested in any of the work we've done or just interested in possibly collaborating. Thank you.
Thank you so much for your presentation, Dr. Hinson. So as a reminder, we will be taking questions after all presentations, so please submit any questions you have using the Q&A panel. We can forward on to the next slide, please. Let us move on to our second webinar presentation, which is being led by Dr. Jessica Keim Malpass. Dr. Keim Malpass is a nurse scientist and pediatric hematology-oncology nurse practitioner. She received her Ph.D. in nursing science from the University of Virginia and has completed additional graduate degrees in advanced practice pediatric nursing, regulatory science, clinical epidemiology, and health economics. Dr. Keim Malpass's research includes translational science, economics, and computational methods that support evidence integration and precision medicine to allow patients, families, clinicians, and health systems to make decisions about novel therapeutics. Populations she works with include adolescents, children, and young adults with medical complexity and severe illness, and those with a hematology or cancer diagnosis. And now I'll turn it over to Dr. Jessica Keim Malpass.
An honor to be here. I just wanted to thank the AHRQ staff for putting this on and also for funding this study, which I'm really excited to tell you more about. So as mentioned, I'm a nurse scientist by background, and of course this shapes everything I do and think about. And much of this work was really garnered from my experience as a nurse, particularly in the bone marrow transplant context, where I would start a shift and have a patient with no overt signs of clinical deterioration or critical illness, and over the course of hours see fulminant septic shock kind of manifest in these really insidious ways. So I became really interested in understanding what can give us more of a crystal ball, or if you're a child of the 80s like I am, a magic 8-ball, to understand who of our patients are going to get sick, who are not going to get sick, and how can we augment our care in a way to give those getting sick the nursing care we need. This R01 speaks to that. So we test a passive display of an AI-based analytic, which I'm going to tell you more about, and really understanding how it prevents hours free of clinical deterioration. Even though I'm a pediatric clinician, this work was done in the adult setting for reasons I can also talk about. So I wanted to introduce everyone to COMET. This is the visual analytic that was displayed in our RCT. As Dr. Hinson already mentioned, human factors is a huge, huge and critical component of AI-based implementation. And so we spent a lot of time working with key end users to optimize and modify the actual display. Just to orient you, these are hypothetical patients in beds, and so your eye is naturally drawn to the patient in bed 9, the patient in bed 15. The x-axis for this unit represents cardiovascular instability, so things like shock, hemorrhage, heart failure. The y-axis, certainly respiratory instability. And you can think about kind of the diagonal axis as certainly a mix of things like septic shock. You are naturally also not, your eye is not inclined to look at the patients at population level risk or below in that left corner, and that's certainly on purpose. These axes can be interpreted like odds ratio. So the person in bed 9 has upwards of a almost 6-fold risk of an event of clinical deterioration within the next 12 hours. The shape of the COMET itself represents a 3-hour window, and this is important because we obviously want to see what happened to our own, patient in a certain amount of time. Are they getting more sick or less sick? And then the leaderboard at the far right is very helpful from, certainly a unit-based perspective. So you can imagine the physician team starting rounds on patients 9 and 15. You can imagine a nurse manager coming in and kind of using that to modify assignments, or the hospital in general using it to kind of get an assessment of acuity. The only other thing I wanted to mention is that the score is updated every 15 minutes, pulling data from both the EKG and from static EMR-based elements as well, like lab values. So it's a highly dynamic score that we can certainly use in real time. It has these overt assessments, as I already mentioned, so things like vital sign and lab results that we already kind of build in our own mental model of risk. But then there's all of these elements from the EKG itself in terms of mathematic computational approaches for signal processing. So understanding pattern recognition, entropy as a form of surprise, and regularity. And these covert elements are, certainly aspects that we're not able to certainly integrate in real time in the clinical context. The other thing is that, there are many scores out there for clinical deterioration, and they all have, definitely optimal use cases. The one thing we really kind of are essential to us is is this notion that we want to make it not based on thresholds to the extent that we can. So the whole premise is that there are these really subtle changes oftentimes that when taken together kind of characterize this overall prodrome of subclinical illness. And so it's often not one specific measurement, but it's multiple measurements taken in conjunction with one another. So I mentioned the first precept is that these, subtle changes often represent a prodrome. Our second one should be no surprise to this group is that early diagnosis and treatment can save lives. We've seen this through the Surviving Sepsis campaign, among many others. Another aspect that's really central is patients get sick in different ways. And so I'm not showing it here, but we did a lot of preliminary work optimizing the model itself to demonstrate this is that, patients, when they deteriorate, they don't deteriorate in one specific way. And so you need a model that's trained on multiple outcomes, but also is able to take the nuance of different parameters, in a way that kind of accommodates for this heterogeneity of deterioration. I will be the first to yell to the high tops that clinician-centered design is critical. Dr. Hinson also mentioned this. If we want to successfully implement these analytics and tools, it is critical to have clinicians involved and part of the design team. So we did really foundational qualitative work to get an assessment of how clinicians would interface with this. We spent a lot of time thinking about to alert or not to alert. And I don't know if we made the right call on this. We will loop back to this. I advocated for us not to alert. I think part of that was my own nursing background. Part of it was the timing of implementing this in 2021 or starting that work when clinicians were incredibly burnt out. So that's something that we'll loop back to discuss. We were thankful to have preliminary work that informed this randomized control trial. These are adult units, ICUs, of course, just to orient. This is a quasi-experimental before and after. Our NICU here is our control unit, so there was no COMET displayed. Our SICU, surgical ICU, we had the COMET display. And so the MICU was just there to get a sense of if there are other hospital-based initiatives that would have also altered the rates. But here we had a really nice early result of septic shock decrease and upwards of a 50% decrease in septic shock. And this is important to us because, these types of analytics, we are not trying to prevent sepsis. Infection control measures prevent sepsis. We are trying to prevent those late fulminant stages of septic shock that require often additional escalation in care. And we saw a really nice result in that regard that gave us the confidence to move forward. As I mentioned, we also spent a really purposeful amount of time with clinicians embedded in their care practices and interviewing them to get a sense of what their perspectives were. It took a lot of time and honest feedback of listening about trust and other elements that they were struggling with. But these are the main themes that were uncovered through that process. And we continue to learn from as we embarked on the RCT. So the RCT itself was a 2-year pragmatic design in, as I mentioned, a mixed medical, surgical, cardiology ward in an academic center. The the beds were randomized to a visual display of Comet. We had a dedicated research coordinator who did attend rounds most days of the week. They would present the Comet score and perhaps a little bit about the Comet trajectory. We had a suggested protocol, but we did not have a mandated clinician response. And this was, again, based on feedback, particularly from our physician and advanced practice colleagues, that they loved having the analytic available, but they did not, frankly, want to be told what to do with it, which I completely appreciate. And so we had suggested responses, and I think that this was an approach that worked well. We did have a recommended threshold, as I mentioned. So we said that if it rose above 2, to go see the patient, but we did not have a visual or an audible alert. Our aims were threefold. We wanted to certainly understand the impact on patient outcomes. Our primary outcome was this survival analysis of hours free of events of clinical deterioration. I just want to put aside that choosing a primary outcome for a study like this is incredibly difficult. And the reason it's difficult is because we do want early safe action, right? So there's a real chance that if you put an early warning system out there, you could actually have more ICU transfers, but those ICU transfers might be more stable ICU transfers. You might be getting the patient the care they need earlier. So it's really, really, really tricky, I think, to come up with a primary outcome that kind of gets the full assessment of what we're trying to get at. That's why we also had AIM 1B. So of those transferred to the ICU, did they have more stable trajectories once they got there? AIM 2 is to understand the impact on clinical action. And so these are time to AIM, so time to culture, time to lactate run, things like that. The third one was an economic aim. So we know it's critical to understand the entire picture and the impact to the healthcare system. This was a cluster randomization that was by bed. This was actually an ethical consideration. We advocated that it would be nearly impossible for individual clinicians to keep track of who was randomized to what. But we did work with clinicians to figure out that they would be open to groups of beds being randomized at a time. And, over that 2-month period, they would get used to who was randomized. They were simply randomized to monitoring via Comet display versus standard of care. Here's what it looked like, just to get a sense of if you were certainly on the control group. We wanted to make it very, very clear that you would not expect to be in the in the group with the other Comet scores. So we first wanted to see how the model performed prospectively. This model itself was trained on this specific patient population, I will say, but we wanted to definitely get a sense of performance. So when we, part of doing this was to assess the reasons that they did experience clinical deterioration. This is just an upset plot. So all it represents is kind of the different patterns or combinations of these non-mutually exclusive reasons for deterioration. So on the very left-hand side, we see the respiratory was the most common. On the very right-hand side, we see 3 things. So arrhythmia, infection, and respiratory all contributing to that deterioration. We also wanted to certainly assess through traditional ways of determining model performance. I will say that in general, clinical deterioration, AUCs, or area under the curve, are certainly more in the realm of 0.7 and above. We wanted to assess how the models performed by sex, and so we did that as well, as you see here. And then we wanted to compare it to something. So we used QSOFA, which is a marker based on more static elements as our comparator here, just to get a sense of how our model did by comparison. And we were pleased that it did outperform QSOFA. So over the 22 months of randomization, there were over 10,000 patients in our cohort. Based on where the study was held, they were majority male, not incredibly representative. and had an older average age based on the diagnoses of this floor. They also have a relatively low length of stay. So a lot of kind of post-procedural stays, and generally patients go home and do well. I apologize. This is busy, but I just wanted to post out of transparency. So we found actually negative findings for our primary outcome. We did not find a difference in hours of free events of clinical deterioration between our comet display and our non-comet display group. We also did a post hoc analysis where we looked at those at risk. And so at risk means that you did have some kind of rise of at least 2 on any of the axes, just to represent that, had some form of instability. And similarly, we did not find a statistical difference on that outcome. What we did find, and this is part of the pragmatic nature, was that there was a lot of bed movement. We thought that there would be bed movement, but we thought that it was going to be pretty limited. And we actually looked at this before the study started. So we kind of looked at open bed availabilities and, is there a concern that a more unstable patient could be moved to a comet display? And I'm mentioning this because, of course, bed movement would be a censoring event. We actually did find in this post hoc analysis that, that there was a higher risk of clinical deterioration among those transferred from a non-display to a display bed. And in essence, these movements undermined elements of the cluster randomized trial by placing sicker patients into comet display beds. And so, this could be viewed as a negative thing. It could also be viewed in a Pollyanna way as a positive thing, meaning that our clinicians liked having it. They liked having that extra information. So certainly it can be looked at in both ways. We also, as I said, had an economic aim, and we have analyzed that. These are preliminary findings that are pretty recent. But we actually found, and I guess I shouldn't be surprised, that there was an increase in total costs for the intervention or the comet arm. And so, and it was statistically significant. This finding was there for both the whole cohort and those at risk. So we did find that there was extra costs if comet was on. We could hypothesize a lot about this, but I feel like, again, out of transparency, this is a very important finding, and one that will be, this was presented at iSport, and one that we want to get out there soon in terms of the manuscript. I think it's just, notable to kind of understand the whole picture as systems make decisions about these implementations. This is just to say that the distributions were similar, which is great in terms of cost. But again, there were more costs in the comet display group. So I have, we were obviously sad about our primary negative finding, but I think that this offered a lot of fodder for future work and kind of reasoning through things that went well, things that didn't go well. I didn't mention, and I should, that when we had preliminary stopping criteria based on sample size, of course, in our sample size calculation. When we went back, our event rate was lower than expected. We think that the post-pandemic period and bed shifts had something to do with this. So in fact, our overall study was unfortunately underpowered for events of clinical deterioration, which also impacted the study. We found that there was this increase in relocating sicker patients from usual care to the display group, thereby kind of certainly undermining the overall design. This study was undertaken during a really critical time in our hospital. And so we definitely implemented it in ways to minimize kind of the energies of our already stretched workforce. I already mentioned that there was a lower event rate that was not expected. Um, I think I already mentioned kind of this alert versus no alert. I would love to study this further. People, I think, really appreciated having the passive nature, and they could pay attention to it when they wanted. They could ignore it when they wanted. But I just wonder if, drawing a little bit more attention to it might have had an impact. As I already mentioned, the primary outcome is just really tricky. And so if you survived and made it home, you were given, there was a 21-day follow-up. So if you survived and made it home, you were credited all event-free hours. If you had a death, you were given 0 hours. And then certainly your first event of clinical deterioration was a competing risk assessment, and you were stopped at the time that you had that event and awarded however many hours you made up until that point. So because this was kind of a generally healthy, which is great, generally healthy medical surgical cardiac floor, luckily events of clinical deterioration here were a rare event, but this does kind of impact the way that we want to think about our study design moving forward. I also mentioned why we chose cluster randomization, but it was an ethically driven decision that really we worked with key stakeholder partners on. So the things, a lot of these findings are hot off the press. Our preliminary outcomes are in a preprint and under review right now. Our academic findings are forthcoming. We still have to do AIM-2 analysis. So that's the time to proactive clinical action. I'm really intrigued by that as a nurse. Also, the post-ICU trajectories, that's also on our next list. I'm also very intrigued of, thinking about the patients that did get to the ICU. What did they look like after they got there? There are many secondary rates of events that we need to dig into. And I care deeply about the implementation considerations. And so again, all of this work just gives a lot of things to think about and consider for subsequent studies. Again, I'm also happy to be contacted, and it was an honor being with you all.
Thank you for that great presentation, Dr. Keim Malpass. And as a reminder to the audience, please feel free to submit any questions you have using the Q&A panel at this time. So now we'll move on to our final presentation of this webinar, which is being led by Dr. William Hsu. Dr. Hsu is a professor of radiological sciences and bioengineering at the University of California, Los Angeles. He is a biomedical informatician focused on maximizing the utility of multimodal data to detect and treat cancers early. His lab harnesses artificial intelligence and machine learning techniques to integrate and transform multimodal data into actionable knowledge. Dr. Hsu is the lead on multiple projects from NIH, AHRQ, and the V Foundation. He is a deputy editor at Radiology, Artificial Intelligence, and serves on the editorial board of the Journal of the American Medical Informatics Association. And now I would like to turn control over to Dr. Hsu.
Great. Thank you so much, Stephanie, and really want to appreciate AHRQ as well as the organizers for inviting me to be part of this webinar. As Stephanie said, I am a informaticist. I am a PhD and work very closely with clinical collaborators. And my hope today is really to leave with you a message that when we talk about implementing AI, it is super important to understand the impact of AI, both in terms of its performance and ultimately to try to anticipate how AI could potentially change downstream or have downstream effects as we implement them. And so I'll be talking a lot about model validation and simulation tools to allow us to understand and anticipate potential unintended consequences of using AI in practice. And so I'm sure you've seen a lot of the recent studies showing the promise of AI in improving the effectiveness of, in my case, breast cancer screening by increasing cancer detection rates and decreasing the reading time of screening exams. This is particularly important in breast screening because we are in a transition phase of adopting new technologies such as digital breast tomosynthesis, which provides better visualization of breast tissue, but also requires more time in reviewing additional images. And so on the right here, I have just an example of two images that was run through a commercial AI algorithm. One of the benefits of actually doing AI is that it picks up very subtle findings. So the red dot that you see there is actually a subtle finding that turned out to be a mass. It was not called by the radiologist at the original time of screening, but ultimately was diagnosed later on as cancer. And what the AI algorithm did was actually, when we ran it on the image, it detected that lesion, or at least the abnormal finding at the original time. And so the premise is, can we actually use AI to detect cancers even earlier? Another feature that I wanted to highlight was work that I did actually with one of my clinical collaborators, Dr. Ann Hoyt, who is a breast radiologist, who we talked about really emphasizing the need to evaluate AI based on their impact on efficiency. And so for those who are not familiar with the current process, what we're hoping to do is transform how breast cancer screening is delivered, really in the hope of improving provider effectiveness and patient outcomes. And so today, breast cancer screening exams are read by a radiologist in batches, typically later in the day or in the next day, long after the patient has gone home. If there is an abnormal finding identified, these exams are assigned essentially a BI-RADS Category 0 assessment, which really means that it triggers a call to the patient who is told that there is a need for a follow-up diagnostic exam, which is then scheduled at the next available appointment date. And so from the time that the patient receives this call to the time that she receives her follow-up diagnostic exam, there's essentially this period of waiting that could be a few days, if not weeks, to essentially to receive this diagnostic exam. And this, of course, can be very anxiety-inducing. And so what we are hoping to do is transform this so that this can be done essentially on the same day. And one of the main barriers is that because we're in a high volume environment, there is no dedicated reader for screening exams during the day. And so the radiologists are currently juggling a bunch of different responsibilities, ranging from performing biopsies to also looking at diagnostic exams. And so what we want to do is use AI to perform real-time assessments, or at least be able to provide a real-time interpretation of the mammograms as they are acquired. So for exams that are read by the AI as either low or intermediate suspicion, these exams are placed in a queue that would then be read by the radiologist as part of their existing workflow. For exams that are highly suspicious or elevated by, as identified by the AI, these exams are then flagged and then immediately presented to the radiologist, who would then make the final determination on whether or not a follow-up diagnostic exam is necessary. And this is done while the patient is still at the clinic, with the aim of scheduling their diagnostic follow-up essentially on the same day, or fitting that exam in while they are at the clinic. And so there are two challenges that I want to really highlight, and this is because enabling this type of workflow, especially with the AI involved, can be potentially disruptive to a high volume clinic. The first challenge is really being able to understand the AI performance and how it would potentially perform on a target population, or at least in the population that we're trying to use it in. And the second one is to, when we do have patients who need a diagnostic exam, how do we fit them in the same day, given the high volume environment that we're working in? And so these challenges motivate the need for analytical tools that will allow us to anticipate potential challenges and mitigate them. I wanted to highlight just a few works talking about model validation and the need for ensuring that the models are clinically useful. The first one is a viewpoint by Nigam Shah, who really nicely summarized that a framework for rigorously evaluating the performance of a model in the context of the subsequent actions it triggers is necessary to identify models that are clinically useful. And this is also very true that AI algorithm performance degrades over time. And this could be because it's being used in a different population than it was trained on, as well as variations in terms of the patient population or even the technology. For example, as we upgrade imaging devices, those images may look different than what the algorithm was trained on. And so these are factors that may influence AI performance. And ultimately, these issues motivate why we need to externally validate or routinely validate a breast AI algorithm to characterize its performance in our target population and assess whether it could be really an initial reviewer or reader for flagging suspicious screening exams. And so a typical design of an evaluation or external validation study looks like such, where we first identify a cohort. Typically, it would be a cohort that you would like to try to target, or at least represent the target population trying to use the algorithm in. We would then try to retrieve the data and to pull, in our case, from our local imaging archive, run it through the AI algorithm. And so in our case, we had a commercial AI algorithm that essentially presented three different ratings: a low suspicion score, an intermediate suspicion, and an elevated suspicion. And we would then take these labels and compare it with some known outcomes. So this would be retrospective data that we would then have either biopsy information from the local registry, or more ideally, a regional cancer registry, whether or not the patient was diagnosed with cancer, because some patients may go elsewhere to actually get their biopsy. And so we wanted to get as complete information as possible. Oh, sorry about that. And so what I wanted to, before I went all the way too far, is really highlight some of the results. And so I know this is a busy slide, but here I just want to highlight that there are definitely, this is just an example of an external validation study where we took about 3,000 screening exams from about 3,000 women, of which about 55 were diagnosed with breast cancer within 12 months. And so what we wanted to do was evaluate based on a comparison with the radiologist, as well as with different thresholds of suspicion. So in this case, we were calling both elevated and intermediate sort of suspicion. And then on the rightmost column is looking at performance specifically on just elevated suspicion. And what you'll see is that depending on the threshold that we choose, you'll have slightly different performance metrics. And so I'll just highlight very specifically sensitivity, which is basically trying to catch as many cancers as we can. And if we have a lower threshold, you can see that our sensitivity is higher, versus on the right side where we have a higher threshold, our sensitivity will be lower. But that is also at the cost of false positives. So for example, if we reduce our threshold to really look at more findings, we'll also have a much higher false positive rate, much more so than the current false positive rate for radiologists. And so one of the decisions that we have to make is really trying to understand what is this trade-off, and ultimately how do these differences change or impact our downstream care. As you can imagine, having the radiologist look at a lot of false positives will have some consequences in terms of their trust as well as their workload in interacting with the AI system. And so just to summarize my first part, number one, it was interesting to note that the AI algorithm really did achieve a high negative predictive value. And so that gave us confidence in terms of the low suspicion exams to actually let them be and not worry that there's any cancers in that group. The second one is that depending on whether intermediate suspicion were included in intermediate review, radiologists would need to deal with much more false positives. And that is, of course, a negative finding that we would want to try to mitigate. The AI algorithm identified several interval cancers that were previously missed by the radiologist. I gave you an example earlier on, and that is a benefit of an AI algorithm. And finally, external validation does provide performance measures that can really help us as we talk about now simulating and looking at what if scenarios of implementing AI, how we can use this information to then simulate what that would actually look like in practice. And so one takeaway, as I mentioned, is that we now have sort of confidence in one of our designs, which was that we could actually put low suspicion exams into a bucket that could be read a little later on by the radiologist rather than immediately. And now what I want to talk about is really how then we analyze the impacts on clinical workflow, and in particular, looking at how downstream of impacts of AI, meaning that if we look at AI's performance, we know that there's going to be false positives. We also know that there will be a number of patients who will truly have a need for diagnostic follow-up. How does that actually affect our radiologists, as well as any downstream impacts on the workflow of our imaging center? And so certainly this has been talked about a lot. There's been a lot of interest, AHRQ funded, that have looked at how health information technologies, such as the deployment of electronic health records, computerized order entry systems, can lead to good and bad unintended consequences. And certainly, there's been a lot of themes more recently reinforced in this commentary that I have on the bottom that relates to the use of breast AI. And there's been a lot of commercialization in this space and the need to carefully consider human-computer interaction and cognitive biases that may negatively impact radiologists' performance. And so one thing that we wanted to do was examine how the implementation of our AI-enabled same-day diagnostic follow-up workflow may impact operations at a high-volume imaging center. And we did so using a discrete event simulation, which allows us to essentially represent the screening workflow as a series of discrete events and allows us to propose what-if questions to support better operational decision making. And we certainly want to use this discrete event simulation to explore potential downstream impacts and identify possible solutions, such as adding resources or changing the way patients are scheduled to mitigate anything that may disrupt, for example, the high volume workflow or become a burden to radiologists or staff members who are providing these services. And so when we first initially developed our discrete event simulation based on information from one of our more high volume clinics, which essentially was a candidate for implementing the same day workflow. We took scheduling data, as I show here, for a period of about a year, as well as we did productivity data in terms of the volumes of patients that were served, the timestamps associated with each of these different services, along with looking at results from site visits, interviews with staff, as well as a time and motion study, really to enumerate the different parameters of the model. And so here you can see on the right, very busy slide, but really just to kind of list out all the different parameters that we took into account. And one that I want to really highlight here is the use of explicitly modeling AI assessments into our model, really to, again, try to anticipate the downstream impacts of our revised workflow. And so this is just a schematic of the model itself, and in terms of the original baseline screening workflow. So each box represents a step or event that the patient goes through during their visit to the screening clinic. The yellow values here are essentially parameters of the model. So N represents normally distributed, and then our mean and standard deviation values. And this is really based on the parameters from the previous slide. In a busy clinic such as the one that we're modeling, you can see that the distribution of exams, screening, diagnostic, and biopsies are all performed at this clinic. And so we want to include all of that because that obviously has a bearing on the availability of personnel and resources to perform add-on diagnostic exams. Now, here is a revised version of that model where we now add in sort of the steps involved in terms of the AI-enabled same-day diagnostic workflow. And so here you can see now we're including a component for AI. We're also including the interpretation of the radiologist and also the potential for recalls that are identified by the AI algorithm. And that leads to then diagnostic image exams. And you can see here that there is actually a variety of different imaging exams that can be performed based on the need for the patient. And so all of this was represented in our downstream model. And just to summarize a few of the results, we first validated our simulation by running the algorithm for 500 days and comparing it with against historical data. And the nice thing is we found that the simulation generated results that approximated our actual patient volume, as well as a percent of screening mammography that day or per day, as well as the average number of recalled patients. And then we asked a series of what-if questions about the patient volume, the wait times, and the length of stay, and how they would be impacted. And as you can imagine, each of them would have some degree of negative impact, such as the reduction, or in this case, about 2 patients per patient slots per day, if we were to try to just maintain our current operating hours and other constraints that we have. And you can also see that wait time would go up and length of stay would also increase. And that said, the thing about the simulation, it allowed us to actually put in or try out some changes to the workflow to try to mitigate these consequences. And so we looked into adding a new mammo unit or opening up one to be able to serve additional patients, looked at adding potentially new staff members or also extending the hours of the clinic. And we could see or start to see which kind of options actually were helpful. For example, in this particular case, adding a mammography and ultrasound unit would increase our capacity for the diagnostic exams. And so with that, that was more effective than just simply trying to keep our imaging center open longer. Another thing that we tried was actually look at how do we schedule patients in a way that would actually allow us to mitigate some of the variability that we can see in diagnostic follow-up. So, for example, right now we estimate that on average about 12% of women require a diagnostic follow-up, but that may vary day to day depending on who is presenting to the screening clinic. And so, one thing that we wanted to do was to see whether we can change how patients are scheduled based on um, their prior breast cancer history risk. And this can be done either using a imaging-based exam. So there's been a lot of interest in using this imaging-based risk model. One's called Mirai that's been recently published, as well as, for example, these clinical risk models like Tyrer-Cuzick, or a combination. And what we're trying to do is place women within low risk buckets like RSS1 versus intermediate and versus high ones, which is RSS3. And so what you see here is instead of scheduling them randomly, which is based on whoever the scheduler is getting and putting in terms of their preferences, we actually now can structure the schedule to perhaps put the higher risk women earlier in the day where we can actually accommodate them better for a same-day diagnostic exam versus later in the day where everything's already behind schedule, and to try to mitigate or at least spread out sort of the potential risk for women who require these diagnostic exams. And so what we find is in our model, we again validated it and confirmed sort of the numbers match what we're seeing in practice. But ultimately, what we see is that we can actually reduce the variability by 30% or so in terms of the recall variance in a given visit, which really helped us at least give more confidence that we're not, if we tried a scheduling approach like this, we could actually try to mitigate the variance and ultimately be or schedule our clinic to be a little bit more regular so that we didn't have to always account for the worst possible scenario where there's a lot of women who require a diagnostic exam and we have this extra capacity that we're opening up and it's not seldomly used. So that was one example of how we tried to do these type of simulations. And so with that, I'll just summarize by saying that our risk stratified screening schedule mechanism could potentially reduce the recall variance. And this is something that we are certainly playing around with to see whether adding this type of risk modeling and scheduling can help us implement a same-day diagnostic service as we move forward. And really, one of the things that we hope is really to, again, showcase the fact that the simulation allowed us to generate some evidence towards getting this type of screening program up and running. And so our next steps really is to look at various different sites. We are certainly actively looking at place to pilot, and we've moved into the implementation phase. We'd like to implement this more broadly. And so we are looking at different centers that we have within the communities to see which one would be the best fit, as well as to talk to our stakeholders to figure out other issues that we need to address. As you can imagine, we have a lot of different things looking at in terms of why we would choose a certain site, other considerations beyond just the AI performance and patient volume that we would want to consider. And so these are all open discussions that we are currently having before we actually implement a service like this. And with that, I would just like to thank the research team as well as my collaborators who consist of breast imagers as well as implementation scientists who have really chimed in on how to implement this, and ultimately AHRQ for the funding of this work, and just really appreciate the opportunity to speak today.
Thank you very much for your presentation, Dr. Xu. And thank you again to all of our presenters for their very informative presentations. So as a reminder, please submit any questions you have for any of our presenters using the Q&A panel. Do make sure to address your questions to all panelists as well in the drop-down menu. So we'll go ahead and move towards the Q&A session now. So please do submit questions. And This concludes the content portion of the webinar. So now we do have a few minutes left for questions. And although we may not get to all questions during today's webinar, we will provide responses to questions in writing as appropriate. You will receive an email once these responses are available. And I want to start with a question that has come in for Dr. Hinson. What is the most challenging aspect of implementing an AI-informed decision-making tool?
The most challenging, the first most challenging is technical. So I think the moving from a study that is published, a retrospective model, if you search, we'll say during the pandemic, for example, because we have a period of time, there were hundreds of machine learning algorithms that were developed, but very, very few were implemented. And that really requires having a team that collaborates with folks like Dr. Shu, who are informaticists and really understand how you get things into the front end of an electronic health record. If you can get over that huge barrier and get things into the electronic health record or into an existing workflow, then I think the challenges become about engaging the user in a way that allows them to understand enough without getting flooded with information. So we're currently still in the phase of kind of overcoming this concept that machine learning or artificial intelligence is a black box, but we use a lot of technologies that are black boxes, right? I saw some ultrasound images, and I saw, we can think about MRI images, CT images. I have no idea how those work, but I trust what I'm seeing because there are algorithms underlying those. So we have to get to a point where people understand enough about how the tools work that they can trust them. But they're not overwhelmed with the complexity that's behind the scenes. So I think those are two of the most challenging things.
Thank you very much for your response, Dr. Hinson. Now I have a question for Dr. Keim Malpass. What are some lessons learned with implementing the comment system and integrating this into the workflow?
So I've alluded to some of the lessons learned in terms of more of the kind of methodological considerations, but I just cannot highlight enough, and these are all themes that have also been discussed in terms of really working on a partner level with end users from the beginning. And I would also argue for a wide range of clinician types and end users from the beginning. Particularly if nurses or other clinicians are kind of the first touch point of the system. And so we worked with them extensively because there were trust issues, right? Any kind of analytic like this, like comment, is going to have a relatively low positive predictive value. So based on, if we were to set an alarm, which we did not, but if we were to set a random threshold of 2, that would only have a positive predictive value in the 30% range. So more times than not, a rise like that would not lead to an event of clinical deterioration, particularly a rare event in this type of population. And so I do think it comes down to kind of using terms and thresholds and trade-offs in ways to work with clinicians to understand that not every time it rises, it means that something bad is going to happen, but it's something that we need to integrate within the other kind of Bayesian ways of thinking, which we all have. We have our own prior probabilities. And I think we kind of use these technologies sometimes to either to augment what we kind of know already. The ways that I think it could be really helpful, though, is if you're at a clinical juncture, or if you're unsure but have a need more objective data to kind of go with your gut feeling, it can be very useful. So I think trust and working with folks really to understand how they want to use it. And the alert decision was based on feedback from nurses. So that is what they told us that they wanted. I think had we not done that work, we might have alerted, and it might have caused some alert fatigue and additional burnout.
Thank you for your response, Dr. Keim Malpass. Now I have a question for Dr. Shu. Information from simulation studies is only as good as how accurate the simulation is in modeling the real world. How would you validate the RSS scheduling algorithm and AI-driven same-day diagnostic triage in a clinical environment?
Yeah, that's a great question. And, whenever we do these type of models, certainly, your model is as good as your assumptions, right? And there's always that quote that, all models are wrong, but some are useful. And I think in this case, some of the things that we tried to do were, as I highlighted in the talk, just try to test our assumptions, right? Certainly looking at and working with our clinical partners to make sure that we're accounting for a lot of the potential factors that may influence the model, and actually doing some studies to actually collect data, and to see how the workflow occurs, try to parameterize our model, meaning put the right numbers in to make the models accurate, and ultimately to run these type of even retrospective analysis where we're actually trying to run the model, compare it with real world data, and to see how accurate or how aligned they are. But that said, certainly models again we're making a lot of assumptions, and so certainly there's a lot of areas for improving our models. Certainly some of the things that I know have been brought up related to understanding, for example, how this type of maybe risk stratified sort of screening paradigm could affect populations that may be underrepresented in sort of our models, ensuring that we make sure that these models are can represent the assumptions hold over time. So these are things that we certainly are continuing to work on and look at. But my hope is that with sort of regular validation and kind of a clear collaboration with the clinicians, that we build a model that ultimately allow us to make better sort of evidence-based judgment in our implementation.
Thank you, Dr. Shu. I have questions for Dr. Hinson. How do you think AI-informed decision support tool interventions will be spread?
Yeah, I think that's a little bit of a challenging question, in that um, we produce a lot of things. I'm first and foremost an academic, right? So we produce a lot of things in academia, and we have the intent for those things to spread, but it requires quite a few resources for a tool like this to spread across a country. So I think it really does depend on like getting a tool to a point where it can be commercialized and then adopted. Due to the complexity, things may change and it may be easier to take these tools and adopt them locally. But I think at the moment, there may be capacity for rebuilding similar tools locally, but for things to be able to spread across the country, I think there's a really good opportunity for academic and industry partnerships. And that's where there are these things called SBIR awards, which our group got an SBIR award and was able to disseminate our tool through that pathway, where these are small business innovation research grants. And so you get tools like that, and you kind of transition to a commercial pathway. That seems to be the most successful for really spreading. But there are opportunities where you can collaborate with other data scientists and other institutions to spread to the places that have the capacity to do that as well.
Thank you, Dr. Hinson. Now I'd like to ask Dr. Keim Malpass a question. While the COMET system models were trained on clinical deterioration events, have they been used in other off-target ways? And what are clinicians' perspectives of this?
Yeah, so this is one of my favorite aspects actually, and one of the ways that we want to extend this work in the future. And so very early on, particularly bedside nurses told us how they were using COMET to make decisions that had nothing to do with clinical deterioration. One of our nurse practitioners literally said, I walk in, I look at COMET, and I can figure out if I have time to go get coffee before I start or not. I walk in and I already mentioned the rounding decision, like let's figure out who we can round with, but also in terms of comfort, right? Like, so we know that pain and sedation, particularly in the ICU and other elements, they have these autonomic signatures that COMET is able to pick up on because of some of the EKG computations. And so The next kind of push we are doing, and this is completely stakeholder driven, is figuring out ways that that nurses and physicians and respiratory therapists and pharmacists also like to use Comet that are not based on clinical deterioration. This can, be problematic in some ways because obviously if the model is not initially trained on whatever event you're assessing, you have the risk of it not performing well or not really getting at what you're intending. But I think that I'm really excited actually in using it to better understand supportive care needs for some of our patients. This is in line with like thinking about how to refine the cohort going forward. So I'm really excited to think about this in the context of heart failure patients in particular and understanding responsiveness to therapy, which is not something that we've done yet. But something I think is hugely important. So what if we treat these physiologic scores almost like a pharmacodynamic marker, right? What is to say that that can't be used to really assess in real time how a patient is responding to a titration or an escalation in care? And so those are the things that I am most excited about. And partially because of my background, but also this is what our bedside partners are telling us too.
Thank you, Dr. Keim Malpass. So now I'd like to ask a question of Dr. Shu. What are strategies for using information from an external validation study to improve the implementation of an AI algorithm at a target institution?
Right. So, when we do these external validation sort of experiments, it certainly, takes a good amount of effort to curate that data and to actually run the actual analysis. But I think it does really give us a lot of insights, both on how we can trust the AI algorithm. Of course, when you look at the sort of the commercial space and when you look at different AI algorithms, everyone's going to tell you that their AI algorithm does, the best, and there's a lot of, benefits to it, but that may vary. You're certainly in terms of when you try to run it on your population, particularly if it was very different than potentially what the model was trained on, and sometimes you don't even know. The vendor is not completely transparent that the model was trained on a very specific population, and so these are things that can help you kind of when you do an external validation, understand, well, how well does this algorithm actually work in my clinic, and using that information, when it tells you things like sensitivity and positive predictive value, these are basically metrics that tell us, well, how many cases potentially would be flagged by AI that ultimately we would need to deal with. And so these are things that when you have conversations with your clinicians or those who are directly interacting with the AI algorithm, that we need to really understand what are the impacts of using the AI, where you may have more false positives, with the benefit that maybe you'll catch some cancers earlier. And so those are things that I think, having more evidence to have those discussions would be helpful before you just run into implementing the AI algorithm.
Thank you for your response, Dr. Shu. So now I have a question that I'm going to ask of Dr. Hinson and then give Drs. Keim Malpass and Dr. Shu an opportunity to respond to as well, if you all would like. This question is, what do you think are some areas of uncertainty in the AI-informed decision support tool space?
So
Dr.
this,
Hinson?
okay, yeah, thank you. Yeah, so that's a great question. I think probably the most uncertain is how we, like related to one of the questions previously, is how we move from having local models that perform well to models that can perform well everywhere. And I mean that like in a couple different ways. So one is related to the questions you've asked about how do you get these things integrated? How do you know how well they're performing if someone else is putting them there? But the other is about just the way models perform. So we know that models, and we've seen it with many of the models we've developed around AKI, for example, or predicting severe outcome for patients with influenza. The model performs best in the population where it was trained. And there are a number of reasons for that. Some are related to the people it's trained in, and some are related in the practice patterns of the hospital. And then they really need to be retrained locally to perform best. And how we will be able to do that and have a regulatory framework that works is a little bit of a challenge. Right now, The regulatory framework that's going to be applied to them doesn't allow for that, but that also results in algorithms that are not ideal. So I think that's a really uncertain area, and everybody's kind of learning as we go. I expect a lot of development in that area in the next few years.
Is there anything that you all, Dr. Keim Malpass or Dr. Shu, would like to add in?
Just add briefly, and I've alluded to it, but so what do we do with this? And certainly Dr. Shu has done some beautiful simulations. That's one way of getting at it. But I do think we need more nuanced methods to understand what we should do with it. And I think for diagnostics, that's a more straightforward pathway. I think for kind of these ongoing time series models, it was it was challenging. But I do think that there's reinforcement learning, as mentioned, discrete event simulation, other methods that can kind of get at this and help us guide clinicians to understand when they should act versus not.
Yeah, and I would just echo what the other panelists said. And in particular, I completely agree. I think the current regulatory framework prevents us from really doing some local adaptation of these algorithms, which may optimize the performance of algorithms. But one other kind of aspect of this is really, getting out how to optimize that human computer interaction. Oftentimes we talk about AI, current phase of AI. Certainly there's been a lot of technical advances, but this is not necessarily new. I mean, certainly at least in breast screening, AI has been around. There was a previous generation of computer aided diagnosis that happened in the 90s that ultimately failed, in the sense that the algorithms, as well as the human computer interaction with the algorithms, really actually reduced provider performance. And so those are things that certainly, as we try to implement moving forward, we should learn from those historical mistakes. But ultimately, I think a lot of things that we just discussed today are helpful tools to try to avoid those type of pitfalls.
Thank you all for your thoughts. We probably have time for just one more question. And so we do have one that came in that says, how do you best get buy-in when you're wanting to place an AI tool in a provider's workflow? And I know throughout you all's presentations, I heard, some things about, leadership and, communication of needs. So I want to see if you all could share, just very quick each, some thoughts about how do you get buy-in and who do you need buy-in from in order to place AI in the clinical environment?
I'm I'm willing to take a brief answer to that, is that you get buy-in before you necessarily develop the solution. So that's the best way to get buy-in, is to involve the users, the end users, in the development of the tool, and then they become a champion of the tool because they understand what it is. If that's not possible, then they become you find an influential individual within the group, and then you train them with the tool. You really teach them how the tool works, and then let them share that with their peers. That's been the two ways that have been most effective for us.
Dr. Shear, Dr. Khan Malpass, would you have anything you'd like to add?
Yeah, I just completely agree with that answer. I think, on top of that, I think, in the past, what I've seen is that those who are the most enthusiastic, right? They are the ones who champion purchasing the AI and implementing it. They often, that's how AI got implemented. But I think more and more we realize that, there's a lot of downstream impacts, and so we can't just have everyone just purchase their favorite AI algorithm. There needs to be some governance. There needs to be some rigor around how we're choosing AI algorithms and figuring out how it's working in our health system. And so I think, more and more there is definitely, at least in our health system, a lot of sort of a formal process for actually evaluating the tools, the use cases, why it's being used, kind of who's going to be impacted by it, and understanding those implications. And I think that is really the right way to go, is to really be able to understand and anticipate these issues. But ultimately, the buy-in comes in from like Dr. Hinton said, like the sort of the enthusiasm and the recognition that the AI can really transform, the task that we're trying to do.
And just to echo, I completely agree with everything. And just to highlight a diversity of clinician types, I think targeting everyone that the analytic will potentially impact is important. Also integrating key infrastructure folks, on the on kind of the health system data side, which is complex, and there's so many different people involved with implementing any kind of analytic. But the last thing I want to say is that, one area that has not been touched is patient and family integration in terms of model development and implementation. I think this is the next frontier. I think I will speak for myself. We did not include patients and families. Prior to my involvement in this modeling group, there was no nurse representation. And so I think, kind of thinking holistically about end users, including patients and families, both in terms of the things that they care about and the ways that that kind of information impacts their entire care pathway.
Thank you very much for all of your responses. So we've reached the end of our time for this webinar. Thank you for attending. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on this slide. You will select today's webinar, which will be indicated by date and title to claim your credits. You will have 14 days to claim your continuing education credits. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will complete the survey, share your feedback with us. Thank you for joining us on today's webinar, and you may drop the call.